Welcome to our Advanced Heart Failure video curriculum series. In this video, Heart Failure 2.0, we will build on the topics reviewed in Heart Failure 1.0 and discuss additional therapies for patients with heart failure. Our objectives for this session are: 1. Outline pharmacologic therapies that may benefit patients with heart failure after optimization of quadruple therapy guideline-directed medical therapy, or GDMT. 2. Identify medications that should be avoided in patients with heart failure. 3. Describe the purpose of implantable cardioverter defibrillator, or ICD, and cardiac resynchronization therapy defibrillators, or CRTD, and indications for these therapies in patients with heart failure. And 4. Describe indications and interventions for repair of valvular heart disease in patients with heart failure. In the previous video, Heart Failure 1.0, we discussed 4 classes of medications classified as GDMT that are Class 1 indications in patients with heart failure with reduced ejection fraction. There are defined target doses for each class of medications that comprise GDMT. However, many patients cannot tolerate these target doses due to side effects, such as low blood pressure or electrolyte derangements. In patients with symptomatic heart failure on optimized GDMT, meaning that patients are either at target doses or maximally tolerated doses of GDMT, there are additional medical therapies that can be considered. This video will focus on the area highlighted in red on the screen. The following recommendations are based on the ACC, AHA, HFSA 2022 Heart Failure Management Guidelines. The first medication to consider for secondary pharmacologic therapy for patients with HFrEF is a combination pill called hydralazine isosorbide dinitrate, or Isordil, which in combination is sold under the brand name Bidil. This medication acts as both a vasodilator for arteries and veins and is used for additional hypertension management once patients are on maximum GDMT. This medication was first studied in 1986 in the vasodilator heart failure trial, better known as the VHEPT trial, which demonstrated a trend, but notably not statistically significant difference, towards reduced mortality with hydralazine isosorbide dinitrate in patients with systolic heart failure compared to placebo. Notably, the standard of care at that time for heart failure management was only digoxin and volume management with diuresis. This trial is most well known because of its hypothesis generating subgroup analysis, which suggested mortality benefit in self-identified African American patients. This prompted additional studies, including the 2004 African American Heart Failure Trial, better known as AHEFT, which compared hydralazine isosorbide dinitrate to placebo in patients on background GDMT, including ACE inhibitor and beta blocker, who self-identified as African American. The authors found a mortality benefit and a reduction in hospitalization when hydralazine isosorbide dinitrate was used compared to placebo. It is crucial to note that the results of this study were confounded, since the African American trial population was more hypertensive and had higher rates of non-ischemic cardiomyopathy compared to most heart failure trial populations. Therefore, the benefit of this medication more likely lies in treating hypertension rather than race-based medicine, which is an inherently flawed premise. This medication is a good choice in patients who have contraindications to ACE/ARB/ARNI, since it does not directly affect kidneys or potassium levels in those who remain hypertensive on optimized GDMT. One downside to this medication includes high pill burden with 3 times daily dosing. Despite the flaws in the history of studying this medication, because of the data demonstrating mortality benefit, there is a Class 1A recommendation to start this medication in patients who self-identify as African American with an NYHA Class 3 to 4 heart failure on optimized GDMT. Notably, hydralazine isosorbide dinitrate should never be prioritized over ACE/ARB/ARNI in patients with any race given its inferiority. Another medication to consider for secondary pharmacologic therapy for patients with HFrEF is ivabradine, which acts on channels in the sinoatrial node to slow heart rate. Heart rate is a strong predictor of cardiovascular outcomes in patients with heart failure. Patients with left ventricular dysfunction and a resting heart rate above 70 beats per minute are at an increased risk of sudden cardiac death and hospitalizations related to heart failure. Beta blockers help control heart rate. However, as we mentioned earlier, not all patients can tolerate a high dose of beta blocker and may still have elevated heart rates. Ivabradine controls depolarization of the SA node by inhibiting funny current channel, which controls the automaticity of pacemaker cells and decreases heart rate. When considering starting this medication, patients should be in sinus rhythm and without any pre-existing conduction abnormalities. In patients with symptomatic, stable HFrEF on GDMT, including a maximally tolerated beta blocker, who have a heart rate of greater than 70 beats per minute, ivabradine has demonstrated benefit in reducing a composite heart failure mortality and heart failure hospitalizations, as in the 2010 SHIFT trial. Notably, in this trial, only 25% of participants were actually on maximum beta blocker dose. Therefore, there remains some uncertainty as to whether the benefits demonstrated are specific to ivabradine or if they could be equally achieved by maximally titrating beta blockers. Currently, ivabradine carries a Class 2B recommendation by the AHA/ACC HFSA 2022 guidelines for those with HFrEF in sinus rhythm with a resting heart rate greater than 70 beats per minute despite maximally tolerated beta blocker. Other Class 2B secondary pharmacologic interventions for patients with HFrEF on maximally tolerated GDMT include digoxin, vericiguat, polyunsaturated fatty acids, and potassium binders. Given the limited benefit and minimal real-world use, additional discussion is beyond the scope of this video. In addition to identifying medications that demonstrate benefit to patients with heart failure, it is also important to discuss medications that should be avoided in these patients due to unproven benefit or potential for harm. Medications without clear benefit include dihydropyridine calcium channel blockers, such as amlodipine and nifedipine, noted at the bottom of this chart. Their counterparts, non-dihydropyridine calcium channel blockers, such as verapamil and diltiazem, highlighted in red, should also be avoided due to potential for harm with their negative inotrope effects and effects on the electrical conduction system. Other medications with potential for harm that should be avoided in heart failure include certain diabetes medications, such as TZDs and DPP-4 inhibitors, both of which have shown increased risk of heart failure hospitalizations and are highlighted in orange, Class 1C antiarrhythmics, such as flecainide, which has increased mortality in those with ischemic or structural heart disease and is highlighted in green, and NSAIDs, which can worsen heart failure symptoms and is highlighted in purple at the top of this chart. All of these medications can exacerbate underlying myocardial dysfunction. Various mechanisms for worsening heart failure include negative inotropic effect, increased SVR, blunted diuretic response, and proarrhythmic effect. Additionally, guidelines do not recommend any vitamin, nutritional supplement, or hormone therapy due to lack of benefit other than to correct specific deficiencies. Next, let's discuss the role of ICD and CRTD in patients with HFrEF. An ICD, or an implantable cardioverter defibrillator, is a battery-operated internal device that can detect and attempt to correct cardiac arrhythmias by providing stimulations or shocks to restore normal sinus rhythm. Patients with HFrEF are at increased risk of sudden cardiac death due to ventricular arrhythmias, and therefore ICDs in this population are used as primary prevention to reduce the risk of sudden cardiac death. Initially, ICDs were studied and implemented in patients who were resuscitated after cardiac arrest, that is, secondary prevention. However, many randomized trials since that time have proven mortality benefit with ICDs compared to placebo or antiarrhythmic medications as primary prevention method in patients who were at high risk of sudden cardiac death. There is a Class 1A recommendation to place a primary prevention ICD in patients with non-ischemic dilated cardiomyopathy or ischemic cardiomyopathy who are at least 40 days post-MI with an EF of greater than or equal to 35% and NYHA Class 2 or 3 symptoms on chronic GDMT and have an expected survival of greater than 1 year. If a similar patient has NYHA Class 1 symptoms, but an EF less than 30% and meets other criteria, there is a Class 1B recommendation. When considering placement of devices, one should always consider if the patient would additionally benefit from a CRT or cardiac resynchronization therapy. Over time, ventricular desynchrony, evidenced by a widened QRS, can lead to worsening left ventricular function. CRT is a pacemaker function, which helps both ventricles beat in tandem, hence resynchronization therapy. This device typically has 3 leads, one in the right atrium and one in the right ventricle, and then one to pace the left ventricle, which does so either from the coronary sinus or from the RV septum in an area known as the left bundle branch pacing. Trials show that resynchronization of the right and left ventricle can result in a decreased mortality and heart failure hospitalizations. It is important to note that CRT can be done with or without a defibrillator. CRT-P denotes cardiac resynchronization therapy without defibrillation, that is pacemaker only, whereas CRT-D denotes cardiac resynchronization therapies with a defibrillator. There is a Class 1 indication for CRT placement in patients with HFrEF who have EF less than or equal to 35%, a left bundle branch block with QRS duration of greater than 150 milliseconds, and symptomatic heart failure to reduce mortality, hospitalizations, and improve symptoms. Of note, there are many other levels of recommendations given for CRT depending on the severity of the left bundle branch block, heart rhythm, and NYHA class as depicted here on the screen. Lastly, let's discuss management of valvular heart disease in patients with heart failure. First, we will discuss mitral regurgitation. Secondary or functional mitral regurgitation occurs due to pathologic dilation of the left ventricle in heart failure, which subsequently causes dilation of the mitral valve annulus, which separates the mitral valve leaflets and therefore results in mitral regurgitation. In secondary MR, there is no inherent pathology of the mitral valve itself, in contrast to structural or primary MR. The first step in treating secondary MR is to optimize GDMT, which may avoid the need for intervention. Patients with persistent secondary MR despite GDMT optimization may need additional intervention. 2 options include transcatheter mitral valve edge-to-edge repair, also known as TEER, and mitral valve surgery. During TEER, a small device often referred to by the brand name MitraClip grabs both the anterior and posterior mitral valve leaflet and holds them together, which helps reduce retrograde blood flow and therefore reduce severity of mitral regurgitation. TEER has demonstrated its greatest benefit in patients with a greater degree of MR compared to their LV size. Mitral valve surgery is considered in those already undergoing cardiac surgery for a different indication, such as CABG. In addition to mitral regurgitation, aortic stenosis, aortic regurgitation, and tricuspid regurgitation are all associated with worse outcomes in patients with heart failure. It is important that these patients be managed by a multidisciplinary group, including heart failure cardiologists, electrophysiologists, and cardiac surgeons. To finish, let's summarize what we learned today. We discussed, first, the pharmacologic therapies that may benefit patients with heart failure after optimization of quadruple GDMT. Second, medications that should be avoided in patients with heart failure. Third, indications for ICD and CRT in patients with heart failure. And fourth, indications and interventions for repair of valvular heart disease in patients with heart failure. Thank you so much for joining. Please check out our other videos in our Advanced Heart Failure video curriculum series for more learning.